Welcome everybody to the first seminar, Department of Public Health seminar of the 2021-2022 academic year. And the overall topic of today's seminar is COVID-19 mitigation measures in North Dakota, a retrospective analysis. And we actually have two of our very own MPH students today presenting. First off, we will have Savita Sidhu, who is a second-year MPH student studying management of infectious disease. She's currently a graduate assistant working at the North Dakota Department of Health, yay. And her research interests include social and infectious epidemiology. So I will be turning it over to Savita.
It's been a really crazy year, but we've been so fortunate enough to look at some of these issues in COVID-19 firsthand. And I'm just honored to, quick question, can I admit people in the-
Dr. Danielson or Angela?
I'll keep on that.
Okay.
So yeah, my paper really looked at managing the severity of COVID-19 using model-based predictors. And this project was really started all the way back in September when Dr. Stephen McDonough, who is in Bismarck, actually contacted Dr. Strand, who is here at NDSU, and wanted to look at, the anomaly of COVID-19 in North Dakota. Cases were rising, and we didn't really know if there was a real model to predict COVID-19 risk within the state. We knew that North Dakota had created one, but it seemed like something was just not going right here. So they developed this research team with both of them, Bosola, myself, and the associate professors here at NDSU, Dr. Rick Jansen and Dr. Adam Homan as well. And we got together and just started picking apart some things that we were really interested in. And I focused a lot with Dr. Stephen out in Bismarck, looking at model-based predictors and how they predicted risk of COVID-19 in North Dakota. So the point of this presentation really is to describe two model-based predictors that we looked at, the North Dakota model and a Harvard University model that was developed that also predicted the risk of COVID-19 within North Dakota. And both of these models, just right off the bat, kind of had different predictions for risk of COVID-19 within North Dakota. And the goal, is really to compare these models for how they distributed the risk across the state from July all the way through December, and to determine really, is there a difference if we use a different model? Are we getting a different COVID-19 reported risk? And if we find that, there is a difference, maybe we can use that as a tool to guide us for future preparedness efforts based on the results of the study that we had, to future policymakers and health leaders as well. So, the existing literature, I'm going to be using the term model-based predictors a lot, and I kind of just want to give a really clear definition for that. And when we say model-based predictor, we really mean, using these predictive statistical methods supplemented by data to look at patterns and outcomes and to figure out if we can truly predict risk. And the current literature really says that it's inherently biased. Model-based predictors are inherently optimistic because, nobody really goes in and checks to see if these indicators that we're using truly work. And in a state of emergency, that's even harder to go back and check your work to make sure that you're predicting risk accurately. So there's lots of variation across models. And even before doing, any research, we figured out in North Dakota, there was already some sort of disparity within, the United States reporting, 96 deaths per 100,000 compared to North Dakota, who was reporting about 162 deaths per 100,000. And when you see that disparity, you expect some sort of disparity across states, but you don't expect this much. And you also don't expect a state level disparity either, because you assume that, everybody's kind of on the same page for how they look at COVID risk, but the state is entirely rural, but yet there were still disparities within the state as well. So we looked at that and we said, there has to be a way that they're predicting risk. And they did have a model in place, the North Dakota model, and that was developed as part of the North Dakota Smart Restart program on May 15th. And keep in mind, at this time, the federal government really had declared a state of emergency, but there was really no unified approach for states to take when they wanted to communicate their COVID risk. And so North Dakota developed this model, and they developed it with the economic resiliency team and the industry working group. And so this is a lot of individuals who have, primarily business interests, and they want to get the state back up and running. So they developed this model, and it had a few criteria. There was really three main criteria within North Dakota's model, and they used the active cases per 10,000, the test per 10,000, and the test positivity rate measured on a 14-day rolling average. And they graded these three criteria kind of on a scale of 1 to 5. So 1 being new normal, we're not really at a state of risk, and 5, critical risk. And that was for each one of these indicators, the active cases, test per 10,000, and the test positivity rate. And so they took those, they added them up, and then they divided them by 3 to get sort of a composite score or average. And that's kind of what was reported to the entire state for their COVID risk. And the governor also had a role in this as well. He made several assignments throughout September and through December as well for what he predicted the COVID-19 risk to be. So that was kind of their model. And then going forward during this time, there was also a model that was developed by Harvard University, and that was developed on July 1st, 2020, and that was developed by Harvard University, specifically the Edmund J. Soffer Institute for Ethics. And this was developed by 7 leading institutions that were doing public health research, and their research really was focused on not only providing a model that all states could use, all 50 states could use, but also a model that gave an indication of risk, but also what to do at each of these levels as well. And their main indicator for risk was daily cases per 100,000 individuals. So for every new COVID-19 case that they had, regardless of where it was, they counted that. And they didn't really incorporate the testing method as much as they did as a metric, as much as they did just the new cases of COVID-19. So clearly, there are some differences within these models already. And so we thought, let's look at these two models and really see if there is a true difference in the distribution of risk. Because Harvard said, North Dakota is really in a state of terrible risk throughout the entire month of July. And that's kind of depicted here in both of these graphs. So this first graph here on the right, this table here, is showing you North Dakota's model. It's got all the 53 counties here listed on the left, and this is all throughout the month of July. Those are represented by the columns, and this green is representing a state of low risk that was communicated using the North Dakota model. And then this is the same thing using the Harvard model, and red really indicates a critical risk within these counties here. And there's such a different distribution of risk between both of these models. And this is before we did any sort of analysis whatsoever. So we wanted to really figure out if these differences in the distribution of risk was really by chance, or if it was really a significant difference. So we decided to compare these two models. And how do we really go about making these comparisons? The first thing we started to do was, we gathered some data. We went to the COVID Tracker website where the North Dakota Department of Health submitted all of their data and looked at that data and picked out the parts that were really the part of the North Dakota health metric, which was the active cases per 10,000, the test positivity rate, and the test administered as well. So we looked at that, gathered data for that, and then we also gathered all of the assignments that the governor actually had given during July all the way up until December, and gathered his COVID risk assignments because we wanted to compare those as well. And then the Harvard model for all of the data there, we just found going to the COVID Tracker website as well. The timeline that we used to compare both of these models was really specific. We didn't want to just, do an entire comparison. We wanted to pick some specific dates, and a few dates that we picked here were July 1st, and that was when the Harvard model was adopted. August 26th was the date when North Dakota as a state had the highest 7-day case rate in the nation. September 23rd was the date when North Dakota had the highest mortality rate within the nation. And then November 13th, finally, North Dakota developed a mask mandate, and we wanted to see if the risk distribution really changed then as well. And to do that, since we're looking at associations, for all the statistical people out there, we used a chi-square test for comparison. And we just got to comparing those two models and found some pretty interesting findings. So when we compared, just before I get to the results here, we actually used a combined scale, and that's very important because the North Dakota metric really used a 1 to 5 scale, and the Harvard Health metric used a 1 to 4 scale to measure risk. And by combining these, we actually had a scale 1 to 4. So the North Dakota model was adjusted slightly by combining risk levels 1, new normal, and the low risk together to form 1 risk level. And so we applied that model and made some adjustments to the governor's assignment as well, so that those risk levels could be on the combined scale. So what do we find? When we got to looking at some of our results, they were fairly interesting. In July, there was really no significance observed across the metrics. So the distribution of risk, the average distribution, as noted by this graph here, was really not very different, whatever metric that we used. All metrics, said that North Dakota was in a state of just low risk. And then when we moved on to August, we actually knew that something was going on, that the Harvard average risk across the counties was changing slightly, and we had already moved to a state of accelerated risk. Yet North Dakota, I think we went a little, there we go. Yet North Dakota, was still in a status of low risk and not even community spread. And the governor's metric had really not changed as well. And that is just incredibly surprising, considering, North Dakota at this time is having the highest case rates within the nation, and yet the state is being labeled in a status of green low risk. And so we see that the Harvard metric is ascending, and these metrics in North Dakota are remaining fairly consistent, and the governor's metric is well below the actual North Dakota health metric. So we go on to September 23rd, when we have the highest COVID mortality rate within the state as well. And significance across the metrics was observed at a p-value less than 0.0001. But again, there's that variation within the models. The Harvard model is saying that North Dakota is in a state of critical risk. They need to implement some type of measure going forward, whether that's mask mandates, stay-at-home orders, but yet nothing is really happening in North Dakota at this time to reduce the spread of COVID-19. And so we get on, moving on to November 13th, ultimately you have had now the highest case rates, you've had very high mortality rates in North Dakota, and still there's this variability between all of the metrics. And for the first time, the governor's metric is truly surpassing the North Dakota health metric, and it's finally agreed on that the state is in a status of accelerated high risk within North Dakota. North Dakota never really reached a state of critical risk, but it did reach a state of accelerated risk, according to the governor and the North Dakota health metric. But on November 13th, when that mask mandate was implemented, again, the Harvard average risk across the 53 counties was in a status of critical risk. And picking apart these metrics really gives us a clearer picture of what happened when I say a bunch of variation across the models. The governor's metric really varied all throughout July up until September, and it was consistently below the North Dakota health metric until about November 13th, when that mask mandate was implemented and it was higher than the North Dakota health metric. And this happened for a few reasons, actually. The governor ended up changing the risk designations midway from September 4th through October 16th. And, I commend the governor on doing that. That's great that you can, listen to the ascending risk and make adjustments as necessary. But these adjustments were lowering the risk level in North Dakota, and he lowered 13 counties to a status of blue new normal. And when you lower the status, you change the net effect of the entire state. So this ultimately meant that North Dakota was in a status of green low risk. And so there was just a lot of variability with that metric specifically. And the variability is even increased when we look at the North Dakota 7-day case rate compared to the United States 7-day case rate. If we take apart all of those testing metrics altogether, the test positivity, the test administered, and we focus on just the active cases within North Dakota, we can see there's really all of these cases in July are continuing to increase throughout this period, throughout when the mask mandate was even implemented, and even shortly after that, it increased a little and then decreased if we're focusing on just the active cases. And again, that was exactly what the Harvard model did. They were looking specifically at just the active cases, and that truly reflected the risk of COVID-19 in North Dakota. So again, what did we really learn when we compared these models, apart from just the fact that, we noted some statistical significances and, they weren't just by chance? We really figured out that the North Dakota model-based predictor lagged in predicting the risk of COVID-19. Back in July, when North Dakota was still in a status of low risk, and then past having the highest case rates in the nation, past having the highest mortality in September, that predictor didn't truly reflect the rising risk in North Dakota. So there's a few reasons, why this might have happened. The North Dakota health metric was very test heavy. You have two testing components in there. You have a test administered per 10,000, and you also have the tests per 10,000, tests administered per 10,000. And then you also have the active cases and the test per 10,000 within the state. And unfortunately, when you have two testing components within that model, you offset the entire average, because like I said, they were grading this scale they were grading the metric based on an average. So you could have a high number of active cases, you could have a high test positivity and tests administered within the entire county or entire state. But based on what your risk level was for each of those metrics, for each of those specific metrics, one could be very high and one could be very low, and a large number of testing could offset the entire average. So that was a majority of the issue with the model. The other issue was the fact that the model was based on a 14-day rolling average compared to a 7-day rolling average. And that 7-day rolling average, or that 14-day rolling average that North Dakota used, it took a long time to reach a threshold of, high number of cases to constitute a public health emergency in North Dakota, compared to the Harvard health model that really used 7-day averages and a per 100,000 population base. So they really reflected the true risk pretty accurately using the Harvard model, using just the incidence of COVID-19. And so some conclusions that we, kind of got from this, apart from just the fact that, these models were different, we later found out that, the Center for Disease Control and Prevention ultimately used a model that was very similar to Harvard's, a 1-to-4 model for the travel recommendations and guidelines that they used for individuals who would be traveling to look at, COVID-19 risk where they were traveling. And it just says, again, that the Harvard model was really ahead of its time. And it was a proactive model compared to the reactive approach that North Dakota really took in predicting risk here. And for model-based predictors, really in the future, model-based predictors are great because they can really assist in the mobilization of, human financial resources, but they really should be driven by scientific expertise. And in North Dakota, this was really driven by the expertise of individuals who had economic interests, apart from the Harvard Health Metric, which was driven by public health experts and individuals who had interests that were not just solely based on getting the economy back up and running. And these risk preparedness efforts that comes with using a model-based predictor should really use valid health metrics. We don't really, need to be so heavy with test metrics that are so heavy within the model. And each of these models should also, understanding that they're susceptible to change, they need to be monitored along the way if certain metrics do throw them off, like tests and test positivity. And these models should also really have an early warning component. And this one lacked, and the North Dakota Health Metric lacked in that as well. And again, models should also have the help of all individuals, and all individuals should find the will to collaborate across borders to ensure the safety of all. And that was lacking in the North Dakota model as well. So like any good study that we can do, there are some limitations of the test that we did, the comparison that we did. We don't know the accuracy of the tests that were reported with the data that we used. It's also unclear whether the testing components pose a threat in other populations. If populations were larger, would our tests have looked differently? There was also a similar model that was used in Kentucky that used a composite score and ran into some of the same issues that we did as well. So again, just to conclude, different models do predict different levels of risk. We figured that out between these two models. Proactive approaches are the good approaches. So in the future, having a model that has that warning component embedded in it is really very useful. And so if we had these good metrics, we can actually have good outcomes that truly reflect the rising risk that we saw in North Dakota. And superior prediction models, for the future should really consider not only just the model itself, but other individuals who are involved in decision making. So yeah, it's a very important thing that prediction models really consider all of these aspects. So without further ado, I really do, again, want to thank the research team for everything they did on this project, creation of manuscripts, all of the advice that they gave about the data, how to interpret it and go forward, starting way back into September up until now. Presenting this has been a very special thing to me since we've worked so hard on this project all together. So I do want to thank them for that. And without any further ado, I will open it up to some questions.
Thanks, Via. That's very, very interesting. Is North Dakota using what are they using now? So when they're reporting out on their county status, are they using the old governor's metric or the health department metric?
I don't believe they're using the governor's metric anymore because I know that he has stopped with his COVID-19 press conferences. So I believe that they're just using the existing model that they've had. And that doesn't look like the dashboard has changed at all either. So again, we don't know how testing has changed for facilities. We don't know if reporting has changed. We don't know if new hospitals have now somehow been integrated into the system or something that has, changed the numbers. But so far as I know that they are still using the same system.
So is the health department's metric then also using, I might have missed that at the beginning, using the test numbers and test positivity as part of the three components?
So they were involved in this creation, and I meant to say that, I think I left that out, but they were involved in this creation along with the governors. But there somewhere along the way there must have been some disagreement between whose opinion we favored and what risk level we're really going to put out. So I know that I think they are still using that model as far as I'm concerned. Yeah.
This is Steve McDonough. Can you hear me?
Yeah.
Yes, we can.
So I don't think anyone's using the North Dakota metric now. On the North Dakota dashboard, they have a link to the CDC website and all the news media coverage of risk right now refers to the CDC risk of community transmission, which is based on 7-day cases per 100,000 and percent positivity. So I basically think that the North Dakota health metric is not being looked at all. The nursing home.
Do you know when, Dr. Stephen, they decided to do that? Because I remember looking that up and I thought they were still using it.
I think it's been several months now. I don't think there was any major announcement, but it was said that the CDC greatly revamped their dashboard under the new administration here. It took a number of months, but there's a lot more information out there. There was before there was cases and deaths per 100,000 and then total numbers. And it's been dramatically improved, and there's a lot more information in there. So I think it's been going on for several months now. So I think the North Dakota health metric, as far as I can determine, has been abandoned.
Last time I looked on there, I thought they were still using that. So my apologies, Dr. Carson. I must have gotten my information wrong. I apologize.
And the other thing is that the nursing homes in the state use a totally different health metric. So they use 7-day percent positivity. So the nursing home system is on a wholly different health metric that's not even close to the previous North Dakota health metric. So right now, best I can determine that the North Dakota health metric is not being used at all, and they're just kind of deferred over to CDC as far as what's going on, which is widespread transmission in practically every county in the state.
So just a comment on this. I mean, I was involved with the governor in the discussions about this in the height of all this, and I was very troubled by how much emphasis they put on the testing.
I just thought there was
And I think it was based on a flawed assumption, really an unknown assumption at the time, was that we could test our way out of the epidemic. We could, if we tested and contact traced and quarantined, we could test our way out of the epidemic. And I think the data would suggest that did not work. And I had been advocating for a more objective measure than any of those, which is hospitalizations per capita. But that's a lagging indicator by probably about a week. So if you're really trying to make a predictive model and when to mitigate, that's maybe not the best either. But all three of those components are heavily skewed by how much testing you're doing. And North Dakota was one of the highest tested states in the country for quite a while. And that just wasn't, as you showed, that wasn't, if you put that in the mix there, you can just blow apart all your predictive capability if you have that in the mix by just testing a lot. And having a lot, you can drive down your percent positivity. It's inversely related to that. And
and I agree with you, Dr. Carson. And it's interesting because when Harvard University actually set out a key metrics for that they were looking at when they started creating their model. And the first thing they really said was, we are still going to use new hospitalizations and deaths within our model along with the incidence of COVID-19. But they knew that some of those testing measures would offset it. So they would say, choose the highest number and take this more proactive approach just to show that, we can still offset the entire average. And so they knew that using that test component was just not going to be displaying the accurate risk. And so they decided, to just remove that altogether and just use the daily incidence. So
Dr. Carson raised an excellent point. That the North Dakota model was based on extensive testing and contact tracing. And what I've tried to indicate is that you're always chasing yourself, or you're chasing the virus, and the harder you work, the further behind you get, because you're always behind the virus and you never get in front of it. The way you get in front of the virus last year was masking. This year is immunizations, vaccinations, and masking. That's how you interrupt the transmission. So when you have a model and a metric based on trying to quarantine and contact trace and test a highly contagious respiratory disease, it's just not going to work. And it was an unbalanced approach. The metric was unbalanced and the public health approach was unbalanced. And I think it's just really important for us to note that the way you get ahead of the virus is people wear their masks, and that reduces transmission, or they get immunized, and that's how you eliminate the virus. And so I think I just want to reaffirm and just thank Dr. Carson for bringing that point up, because I think it's a critical observation.
So we had some questions here in the chat from Kathleen Swanson. I don't know if I can see your face here if you have your video off, but you asked whether it is accurate to conclude that the North Dakota model was politically motivated. So this is a really good question, and this was kind of controversial when we decided to add this in the manuscript or not. And from my understanding, it was politically motivated, but the evidence for that, there are articles that you can look up of interviews that the governor has done regarding, his stance towards any sort of mitigation measures, whether, it's masking up, social distancing, stay-at-home orders. And he really believed it was an individual effort. And so the high number of cases don't just happen out of nowhere. This is not some sort of isolated incident. This is the agreement of individuals who believed that we really don't need to take this seriously. And if we do, only a certain people need to. So that portion of the model, I would say, yes, was politically motivated. Other facets of the model, I'm not sure, but there are interviews and specific texts that have said what the governor's stance was. So I do believe there was some political motivations behind that, definitely. Does that answer your question, Kathleen? Kathleen, did we lose you here?
No, she said
replied
yes.
in the chat.
Okay, sorry. Didn't see this. Okay, great, awesome.
Do we have any other questions from the audience?
I think we have a question from Gretchen. Are there policy changes and or development takeaways from your research for the future? If so, what do you think that there are? I do think that in this state, there should be some strict policy implemented about how we look at predictive models and how we look at risk, and we should really be looking at things from a proactive stance. And this is a great question for my friend Bosola, who's going to be presenting here next, because hers talks a lot about the role of mitigation measures and possibly implementing policy to reduce the severity and spread of infectious disease. So I do believe that it is necessary, and if it was necessary in this state, we certainly wouldn't have been seeing the ascension of risk that we did. So yes, I do believe it's necessary, and I hope that they implement it in the future. Or I hope that there's some other states that they can look at, and states that did implement some mask mandates that are Midwest, they did do fairly better in terms of their COVID cases and COVID mortality. So I do think it is important, yes, and they do need some significant policy changes for the future. Okay, if there are no more questions, I will hand it off to my friend Bosola here.
Next up, we have Bosola Shyllon. Bosola is a second-year MPH student at NDSU. Her specialization is in epidemiology with a sub-focus in the management of infectious disease. Since the onset of the COVID-19 pandemic in North Dakota, she has worked with the North Dakota Department of Health as a case investigator and contact tracer. Bosola will be presenting on her research on evaluating the impact of mask use on COVID-19 in the United States. She observed the possible relationship between the implementation of non-pharmaceutical interventions, or NPIs, particularly mask wearing, and the severity of COVID-19 in the US. Bosola, I will turn it over to you.
All right, thank you. Good morning, everyone. I hope you can hear me well. Hi, everyone. My name is Modelbased Shyllon, but I go by Bosola because, people say Modelbased is too long. And my research was on evaluating the impact of mask use on the severity of COVID-19 in the United States. And as Savita rightly mentioned, this research was done, we started doing it since like January, and we gathered the data, we analyzed it to be able to understand the effect of mask use on the severity of COVID-19 in the United States. So what I'm basically going to be discussing and what this research aimed to achieve was to assess the association between mask mandates and the severity of COVID-19 by state in the United States. We all understand that when it comes to policy making on some issues in the United States, state governments are the ones saddled with the responsibility of making those decisions. And in the case of COVID-19, this was also the case when we had to do mask mandates in the states when we were hit by the pandemic. So the severity of COVID-19 in our study was measured by the hospitalization and the mortality rate. And we, based on the analysis and the data we collected, we formulated recommendations going forward on what can be done and how we can best tackle the issue of any incoming pandemic in the future. So we understand that non-pharmaceutical interventions such as mask wearing is not a new thing in this time of history. It has been used as a measure to prevent the spread of infectious diseases. In the Manchurian pneumonic plague in 1911, masks were used to reduce the spread of the virus, as well as in the Spanish flu in 1918. So it is fitting that at this time, based on the magnitude of the pandemic that the world is facing, and based on the infectious disease that we are tackling, that masks are fitting as a mitigation measure. So what exactly did we want to find out? What was going through our minds when we were coming up with all these ideas? We said, okay, so what is the effect of mask mandates on the hospitalization and mortality rate of COVID-19 by states in the United States? We all know that mask use has been a bone of contention since the beginning of the pandemic in the United States. And there has been a lot of theories, a lot of ideas, a lot of thoughts on whether masks are actually effective or not. So we felt like, having an evidence-based approach to this issue will best give people an idea on what to do and how to make decisions going forward when it comes to infectious disease of this nature. So how did we carry out what we did? We grouped the 50 states in the United States into 3 groups, plus DC as well. And we had the early group, we had the late group, and we had the never group. Now, the early group were those that implemented mask mandates earlier on in the pandemic. That's between March to June of 2020. And the late group were those that implemented a mask mandate between July to December of 2020. And the never group were those that did not have a mask mandate at all between March to December of 2020. Excuse me. So the reason why we put June as our cutoff is because in June of 2020, that was the time that the United States recorded the lowest case rates during the pandemic. So we felt like, at that point in time, states that had already implemented a mask mandate within March and June had already seen the effects in regards to the number of cases that they recorded going forward. And then afterwards, we had the late group, July to December 2020. So the data we used was collected from the COVID tracker website, and the hospitalization and mortality rates were collected on per 100,000 and a 7-day rolling average. Also, we assessed the demographic variables and how they were related across the groups from early, late, and never. And that data was also collected from the Census Bureau. After we collected all this data, what did we do? We analyzed it using RStudio. And for statistical tests, we did ANOVA and chi-square tests to ascertain significance as well as the relationship between these variables. So this table is just showing us better on the explanation of the states between the groups from early, late, and never. And we can observe from this table that between March and June, we had about 15 states, like I said, that implemented a mask mandate, which were the early group. But then when there was this, the bomb, and I think Savita mentioned this in our presentation, that in July, there was a high number of cases. It is noticed here that about 12 states immediately responded and reacted by implementing mask mandates. And that was, a little steady up until October, November, when, after Thanksgiving and travels, the country as a whole had an increase in number of cases, and immediately also 7 states between October and November implemented a mask mandate, which North Dakota is part of them. So this is just to show that a lot of states that actually did implement a mask mandate later in the pandemic were indeed very late. And this is because maybe quite a number of the states were reactive in their approach. They felt that, we're not going to implement a mask mandate until we feel that, people are dying, or maybe the hospitalization rates are going so high. And then so there is the more reactive approach than a proactive approach, as Savita also mentioned in our presentation. And then the never group were 12 states who did not even implement the mask mandate at all during the pandemic. So we went on to actually do a visual representation so that we can understand the distribution. How were those states? Because I've just been saying state. So it's like, which states are in these categories. So we can see that it's a random distribution. It's not like as if the early, the late, and never clustered in different parts of the country. But it is noticed here that it's a random distribution. The early is the green, the never is the red, and the late is the brown. So there's a random distribution of states across the groups in the country. So after we collected the data and we analyzed it using RStudio, we developed some figures that shows the relationship between hospitalization rates as well as mortality rates across the groups in the pandemic. Now, this figure shows the relationship between the mean hospitalization rate per 100,000, and like I said, it was collected on a 7-day rolling average between March to December of 2020. And the green line represents the early states, the red line represents the late states, and the blue line represents the never states. Now, we can see here that early on in the pandemic, states that were hit early on, like New York, Connecticut, it responded by implementing a mask mandate. We can see that between May, there was an increase in the number of hospitalization rates. But after those states implemented the mask mandate between March and June, we can see a steady decline in their number of their hospitalization rates till December of 2020. While the states in the late group were not hit early on, severely early on in the pandemic, and they had a low number of hospitalization rates. But between that cutoff mark of June, July, we can see that there was a variation in the lines that the late states began to increase. And for the never, it was a steady increase from March to December. I'd also like to point out here that for July of 2020, the reason why we had that high peak was due to an outlier, which is Alaska, that had the highest number of hospitalization rates in July in the never group. So that makes that peak to be really high there. This figure also shows the relationship between the mortality rate and the state groups across the months between March and December. And in a similar fashion with the hospitalization rate, we noticed that the early group were the ones that had a high rate of mortality in the pandemic. And when, between March and June, as we also observed in the first figure, that when they implemented their mask mandate, they had a reduction in the number of mortality rate because transmission had reduced, and so it came down. And we can see that the lates were somewhat in the middle, and they never were. It's later on in the pandemic and it increased. But I would also like to note here that we understand that between September, October, November in the pandemic, there was an increase in the number of cases in the United States as a whole. And for the late group, which is the red line, that increase or the overlap over the never group was due to North Dakota and South Dakota, which had the highest number of mortality rates, 100,000 in the country at that time during the pandemic. So that's why we observed that, switch between the late and the never during that time in the pandemic. Like I said when I was discussing about the methods, that we did assess some demographic variables to understand that, okay, what other variables would come into play in this state categorization? What other association could, make a difference or could make us understand more? And we can see here that states in the never group had the highest percentage of rural residents, as well as the highest percentage of residents with no health insurance, as we can see, 11.1%. And states in the never group were governed by 100% Republican governors. And just like Savita mentioned in our presentation that, the governors' risk assessment and governors, making the decision, that also affected the way mask use was perceived, or mask adherence was perceived in those different states. So this research was not done blindly. There's been various research that has also been carried out since the beginning of the pandemic in the United States, and they have assessed various non-pharmaceutical interventions and how they relate to the spread of COVID-19 in the United States. This was a study done by Fisher et al. And the researchers, they assessed the relationship between mask adherence and mask policy on the percentage of COVID-19 rates in the United States. So what they found out was that mask policy is related to mask adherence, and that in turn affects the transmission of the virus, which ultimately affects the rates of COVID-19 in the states. On the left-hand side is states with low mask adherence, and on the right-hand side is states with high mask adherence. And as you can see, that low mask adherence led to a high percentage of COVID-19 rates, and high mask adherence in relation to mask policy also led to low percentage of COVID-19 rates in the United States. Also, this is another study that was similar to the study that we carried out, where states were categorized into 3 groups. This was carried out by Ribeiro et al. And they grouped states just like we did into 3 groups. We had the never, the late, and the early. And just this figure A just shows the relationship across these groups in relation to the COVID-19 case rate per 100,000 per day. And just like I mentioned in the figure that I showed us, we can see that the early states were the ones hit first, and then after they implemented their mask mandate between that period early on in the pandemic, there was a gradual decline in their case rate per day, whereas the never state, which is the red line, had a steady increase in the number of COVID-19 case rates per day. Then figure B is showing us that it's sort of buttressing what I just explained that Fisher did, which is that early mask mandate also influences mask adherence. And we can see they surveyed Facebook users, and you can see that states that had the early mask mandate had a higher percentage of their residents using masks, and states that did not even implement at all had a low percentage of their residents of the state actually adhering or deciding to use the mask. And figure C shows so what they did there was normalizing the number of the days between when masks were implemented and when masks were not. And on the left-hand side of time zero, we can see here that at this point, no state had implemented a mask mandate. And it was just, the steady number of cases. But the demarcation when states began to implement, and we had the early, the late, and the never, the early, the blue, the late, green, and the never, the red. You can see that variation where the number of cases of COVID-19 in the early state were coming down, and the one in the never state was going up. So this research is just trying to buttress the fact that mask mandates are actually effective in preventing the spread of infectious diseases like COVID-19. So this study that we did shows that there is a positive association between mask use and severity of COVID-19 as measured by the hospitalization and mortality rates. And this study that we carried out, as well as other studies, can serve as a guide to, come up with policies that would help to prepare future pandemic in the United States. So what do we recommend as a research team? The mask work. We understand that there's been, controversy with that, but we understand from the evidence now that masks do work and they should be employed as a preventive measure against the spread of COVID-19 or any kind of infectious disease going forward. And the federal government should try to work in collaboration with the state government when it comes to planning and logistics for pandemic preparedness. And this third one is also important because, as Savita mentioned in her presentation, that when the government was trying to come up with the risk level, that most of the people on the panel did not have prior understanding on, the nature of infectious disease. So we believe that involvement of state health departments in policy making against spread of infectious disease should be promoted so as to have a better approach to preventing spread of infectious disease like COVID-19. Our study did also have some limitations because we only assessed mask wearing. We did not assess other non-pharmaceutical interventions like social distancing, stay at home, even mask adherence, and how those come into play together with mask wearing in reducing the spread of COVID-19 in the United States. I'd like to once again also thank everyone on the research team for their help, their guidance in starting the project, collecting data, analyzing it, and interpreting it. And I want to thank everyone too for their time, and I would give it up for questions. Thank you.
Okay, we do. We have actually one question off the bat.
Okay.
She said, I'm not sure if I missed it, but I would love to ask what the current trend is like regarding our current, regarding our current COVID vaccination rate and the use of masks. Do we see a drastic reduction in COVID transfer rates?
That's a very good question. So you're asking maybe with vaccine, I think, and I haven't, done the research, so I'm not going to say I did the research, but I think that based on when we were collecting our own data, and at that time there were no vaccines, and there was that variation in mask use. I feel like now, since most of the states have lifted the mask mandate, because when I was talking, I said mask mandate is also in relation to mask adherence. So a lot of mask wearing has reduced, like percentage of mask wearing has reduced based off of states no longer implementing mask mandate. And like you said, the advent of vaccination, I believe, has also made people to become lax in wearing masks as well. Yes, sir.
So I want to thank you for your research and excellent presentation of how the different states did with their mask use and how it affected hospitalizations, mortality. We have a similar experience within North Dakota counties and a divide between the Red River Valley and the rest of North Dakota. I'm not sure if Dr. Carson's still in the room, if he could comment on this, but I've been watching and looking at Grand Forks and Cass County. So those of you not in North Dakota, Cass County is where Fargo is at, and Grand Forks is north of Fargo about 70 miles, and they're in the Red River Valley. Their mortality rate is about half that of Burley County, whereas the state capital where Bismarck is at. So we see huge differences. It's cumulative mortality since the beginning of the pandemic a year and a half ago in the two largest urban areas in the eastern part of the state, and then in the urban areas in the western part of the state of a significant degree. It's almost a twofold or higher. Right now I'm looking at hospitalization rates and childhood COVID infection rates in Burley County, Bismarck, and Cass County. And basically Burley County has twice the hospitalization rate, more than that of Cass County, and twice the childhood infection rate of COVID as Cass County does. So in Cass County, the Fargo School District implemented a universal masking, and they're one of the few school districts that did that. And then Bismarck did not do that. So even within our state, now we unfortunately don't have a lot of data, hard data on mask use, how it varies in the state, but anecdotally, it's much better in the Red River Valley than it is in Western North Dakota. I think social distancing is similar to that. So right now in Western North Dakota, it's basically like there's no pandemic, that doesn't even exist, because mask use has got to be in that 15 to 20% range. And the immunization rates are much lower in a number of the rural counties and western counties than they are out east. So we see a big difference East North Dakota versus West North Dakota on mask use. Not a lot of data, but immunizations, a lot of data. And we see big differences with childhood COVID infection rates. So the question was asked how things are going right now with mask use and vaccination rate. Our state overall has the 47th worst immunization rate in the country out of 50 states, District of Columbia and Puerto Rico. So there are 5 states that are worse than us. So we have one of the lowest vaccination rates in the country. And out west, we have some of the lowest county vaccination rates of any county in the country. It's like Mississippi and Alabama and Western North Dakota. So I don't know, Dr. Carson, do you have anything you'd like to add on to that?
I would agree with your observations. I think if you're, in talking about the hospitalization and mortality disparities from west to east, I think that's probably mostly accounted for by the differences in immunization rates from west to east. We're more immunized in the eastern part of the state than in the western part of the state. Hospitalizations and deaths are still primarily in the elderly, and so I don't know how much masking is affecting that now. And I can tell you, we can go around Fargo now and see not very many masks in most places. But I do want to ask Bosola. So I would agree with you, Steve, but I think vaccinations is the big thing there. I think. I do want to ask Bosola. I don't know if you can share. If you can just put up your last, your fourth from the last slide, maybe, Bosola.
Yeah, I can do that. You mean?
Start like where you kind of get to your conclusions and.
Okay.
Yeah, right about there. Start there. So I just want to play devil's advocate a little bit with you, if you don't mind. You rightly point out this is an ecological study, and the other studies that you showed were also ecological studies. And if you go to your next slide, your first bullet point is a conclusion that masks work based on this data you showed. Based on the classes you've taken so far, do you think you can make that bold of a statement?
No, sir.
I would agree with you there. I think you say you've got a good hypothesis that masks work, but these are ecologic studies. And go to your next slide, please. So your first bullet point there is the study only assessed mask use. Actually, it didn't assess mask use. What did it assess?
Mask mandate.
Correct. So, you know, in an ecologic study, you're looking at overall trends in you're not actually looking at the use. So, and then and then on that same slide, you posit other things that weren't assessed. And I mean, those are pretty big potential confounding variables, right?
Mm-hmm.
You know, stay-at-home order, social distancing. Can you think of any other confounding variables? If you go back to your graph go back, what, no, go to slide 12. Right there. So you look there at the early mask group in your slide in the top left, and you see huge number of cases in the blue line, the early mask mandate group, early in the epidemic, right? What states were those?
New York, Connecticut.
Yeah, right. So all those states that had that big early surge, right?
Yes.
Kind of went through it.
Mm-hmm.
They had 28% in some studies, 28% immunity before we were really hit here.
Mm-hmm.
So I just want to kind of, I think we in public health have to be really careful about our bold dogmatic proclamations when we have modest evidence quality. That's what gets us in trouble, and we lose trust. So I think you've shown evidence that raises a very good question that masks might be really helpful. But this isn't like nail it home. There are any other explanations for what drives rates down in these different states, and you've some of them. Are you aware of any studies that are higher quality now, since you've been doing this work, that address this more directly?
No, sir.
Okay. So about 2 weeks ago, a big study was put out in preprint in Bangladesh, which was a cluster randomized controlled trial of multiple different villages in Bangladesh. And that's worth noting. I don't know if have you already submitted your manuscript?
No.
Yeah, I mean, it might be worth, noting that one, because that study was the first to have really high quality evidence showing masks, training and encouraging masks, at least in Bangladesh, improves mask wearing, and it reduced COVID cases in the elderly. So it really didn't work across the board. And the COVID cases dropped from like 8.6% of people reporting, COVID-like illness to like 7.6%. So it was an absolute risk reduction of 1%. That's something. It's worthwhile. But I think we want to be careful and prudential about what we say. That's all. But this is really good work. It's a good ecological study. It's one more I think is worth publication, but it asks questions and helps raise what I would say is the precautionary principle. Like, it looks like it might help, doesn't cost a lot, doesn't harm people. We probably should be doing it. But I don't think you can we can pound our fist on the table and say, there we have it, masks work, everybody mask up. That's
yeah.
what
Thank you very much.
Do we have other questions from our viewers in the room or viewers online?
This is Steve McDonough. Can I make one comment?
Sure.
So I've looked at the mask wearing in the 4 states, North and South Dakota, Minnesota, and Montana in October. The mean mask use in those 4 states, and the cumulative mortality rate for COVID, which most of the mortality took place in September, October, November, December of last year. And this is an ecological study, but it's just in our region of the country. And there's an inverse linear statistically significant line that goes with Minnesota having the highest mask use and lowest mortality rate, down to South Dakota having the lowest mask use and the highest mortality rate. And I think that was a time period we did not have immunizations, and there's no question in my mind, and I've not looked at social distancing and I've not looked at the number of tests that can be done, but it's the single greatest explanation that I am aware of that explains the vastly different mortality rates in Minnesota, Montana, which are lower than ours and lower than national average, and North Dakota, which is higher than the national average, and South Dakota is way higher than the national average. So I would say that the single greatest explanation is why our 4 states in the north central United States had such a difference in mortality rate, that the single greatest explanation for that is mask use by the population. Now, there may be other explanations for that, but I'd like to get Dr. Carson's opinion on that. Now, that was last year. I think this year, the immunizations are far more important because mask use has kind of disappeared outside of healthcare and a few school districts. But last year, before we had vaccine, I think it was by far the single most important explanation why some states did terrible and some states did better. Dr. Carson, do you have any comment on that?
Yeah, Dr. McDonough, you and I have looked at that data together too, and I agree. I think that's probably the best explanation. But I do think, I look at like Minnesota, which probably, I think it would be interesting to know like what % of people were able to work from home in a state, in North Dakota versus Minnesota versus South Dakota, and how many people, when I looked at the social distancing thing, which is estimated by cell phone, GPS mobility, Minnesota was way better than us too on that measure as well, and South Dakota was the worst. I think it's a combination of things, but the other thing that I think we can say is like, and you would know this better as a practicing, up until very recently with your probably well-deserved retirement as a practicing pediatrician, is influenza disappeared like last year. I mean, just influenza and RSV till this summer here. I mean, the last winter disappeared, and I don't think there's any good explanation for that other than masks. So no, I think they work. The other precaution I would have though is if we really believe that the Delta variant has a reproductive number of something on the order of chickenpox, 6 or 7 or more, that might suggest that there is maybe a component of aerosol spread rather than just droplet spread. And masks might not really work as well for that. I'm not saying don't do them. I think we should be wearing them. I think the precautionary principle applies, but it may be a different animal now than it was last year too, if it really is that contagious and maybe being spread by aerosol, then our little cloth masks and surgical masks might not be doing a lot.
Right, and I think we can expect that there are going to be cases in schools which are doing universal masking. And there was some estimates out recently, last week or two, by modelers, is that you can reduce COVID transmission by wearing masks, but it's not 100%. So until we get a vaccine out there for kids under age 12, our kids are going to be susceptible. I mean, I think there are definite reasons to advocate for universal masking to reduce some transmission, but it's not going to be adequate. The way you get rid of diseases is you immunize them away. And that's by far the best approach. But I think masks played a very important part last year and still have an important role this year.
And if I could encourage Bosola and Savita, I don't know if you're still working as GAs on the same project or if you've got, more time on this, but Now you've got the opportunity to take it up a level with a prospective cohort study. You've got a natural experiment right here in Fargo with the Fargo public school system mandating a mask and the West Fargo public school system not. There's a nice little prospective cohort in the same geographic area, similar demographics, similar population. It'd be very interesting to see.
Thank you.
Regarding the mask utility and the fine aerosols, there was a study recently published in the Clinical Infectious Diseases Journal that showed mask use was less effective with the fine aerosols. I think reduced viral RNA by 48% as opposed to the more coarse aerosols by 77%. So as we move into the Delta variant with the finer aerosols, the masks are becoming less effective at preventing transmission.